This conference will now be recorded.
Good morning, friends. We have gone through some of these topics last time, but because of hurry and next hurry, I have gone so fast. These are important topics. That's why I'm repeating a little bit of previous topics. Uh, am I audible? Okay. Cellulitis, which is one of the most common infection we will come across in general surgery practice, is cellulitis because it can occur in those who have immunosuppressed states. Immunosuppressed states like diabetes. Actually, now India is becoming the diabetes capital of India world. Most of the people are having diabetes, and those people will have immunosuppressed states, and those people are easily get infected to this cellulitis. Cellulitis is nothing but infection of cellular skin and subcutaneous tissue. Infection of normal skin flora or exogenous. Normal skin flora is nothing but a Staph aureus and beta hemolytic Staph aureus, and it is a gram-positive organism. So, infection of this cellulitis is treated by gram-positive coverage bacteria. In a small infection of hand, because they are in immunosuppressed state, it was infected. See these red lines through over the hand. This is nothing but lymphangitis, which accompanies with the cellulitis. These are some presenting features like redness are will be present, and pain. And predisposing factors are diabetes, alcoholism, malignancy, drug abuse, venous stasis, and lymphedema. These are some examples of cellulitis infections. It is a clinical finding and it can be diagnosed clinically by seeing it. No investigations needed for diagnosis, but for treatment you may need some diagnosis like swabs or culture and gram stain to give whether gram positive is enough or gram positive plus negative is needed or not. Management by if limb is affected, elevate the limb and treat the underlying cause. Antibiotics should be given, gram positive coverage. Actually, we have covered all these in last class, but because this is important, I am covering it. Some local complications of cellulitis are blisters, skin necrosis, traumaphromatosis, hidradenitis, and abscess. Systemic complications are bacteremia, septicemia, osteomyelitis, and meningitis. You need to understand these names. Bacteremia is nothing but spread of bacteria through veins to other part of the body. Septicemia is along with bacteremia, some sepsis features will be present. Sepsis feature is nothing but organized infection all over the body. And osteomyelitis is infection of bones you will come across with in orthopedics. On meningitis, infection of meninges. And next up is skin abscess. It is a subcutaneous localized collection of the pus. Uh, you will have the history of penetrating injury and infection of symptom may occur. You can see the central part of the abscess and the surrounding is cellulitis. Cellulitis is common with along with this abscess because abscess is nothing but a collection of pus, and this pus is one of the risk factor for inflammation of surrounding tissues. Cellulitis present swollen, soft center, feels like fluid underneath and painful underneath. This can be treated by incisional drainage and and gram-positive coverage antibiotic. And necrotism fasciitis. This is one of the surgical emergency, and patient who are not treated with this condition may succumb, means they may die. Mortality is 30 to 50%. See, whatever you see is the infection, and underlying the skin also infection is spreading. Because of this, skin infection is spreaded so rapidly. So this is real photo. Blackish thing is nothing but skin underlying the tissue, and this is one of the peculiar feature of the necrotizing fasciitis. Uh, some peculiar smell will be present. Fish odor will be present. Soft tissue crepitus will be present. You can see this red circle, uh, collection of air underneath the tissues. This is nothing but a airborne organisms are present in these necrotizing fasciitis. Clinical findings in necrotizing fasciitis, early findings and late findings. Pain, cellulitis. Pain, cellulitis, what we have studied until now. Pyrexia means fever. Tachycardia means increased heart rate. Swelling will be present, and skin anesthesia will be present. And late findings are severe pain, skin discoloration, blistering, hemorrhagic crepitus, and discharge of dishwater fluid. And severe sepsis or systemic inflammatory response syndrome, multi-organ failure. Multi-organ failure is nothing but involvement of two or more organs is multi-organ failure. Treat aggressively and promptly, otherwise patient will die. As you all know, this 30 to 50% mortality is there. Type 1 broad spectrum combination amoxicillin, imipenem, levofloxacin. Type 2 benzyl penicillin and clindamycin. See, this is the necrotizing fasciitis of back following trauma, and after debridement, you can see the skin of these gentlemen, and it can be treated only after infection is subsided by giving some flaps from other parts of body and grafts. Staphylococcal scalded skin syndrome. It is exfoliative and epidermolytic toxin, rapidly spreading tender erythema, dermonecrosis. It is a recurrent disease of newborn. Most severe form of staphylococcal scalded skin syndrome is recurrent disease. It affects infants, immunosuppressed, renal disease, malignancy. Mortality is higher in adults. Diagnosis by clinical and culture. Frozen section examination of skin and shows state. Treatment IV antibiotic and nursing care are self-limiting. Hidradenitis suppurativa. This is also one of the opportunity infection of the in diabetes or immunosuppressed patients or obese patients. It occurs in apocrine sweatlets. Apocrine sweatlets are axilla, perineum, and areola glands. As I have already said, this is a mnemonic in the name of the apocrine glands only. APO. A means axillary sweatlets. P means perineal. O means areola, which looks like O or circle. We can identify. And these apocrine sweatlets are more prone to hidradenitis suppurativa. Worse in obese individuals, weight loss, oral retinoids, and zinc gluconate will be clear. Erythrasma. It is a chronic skin infection of Corynebacterium. Corynebacterium previously is called as bacterium, but now it is kept in separate species. Mm. Macular wrinkled, slightly scaly, pink, brown, or macerated white areas. Armpits, groin, or between the toe webs, this can be present. Coral pink under wood slide. Treatment is topical citric acid and glycogen. Pyomyositis. It is nothing but pyomyositis. If you break the name only, you can know what is the present feature. Pyo means pus. Myositis means inflammation of the muscle. So now we can come across the what is the underlying thing. Pus filled abscess inside the muscular tissues. Most common organism is Staph aureus streptococcus infection of the skeletal muscles. Most common in tropical areas, myositis tropicalis. Its treatment is drained surgically and antibiotics. gangrene. Until this we have covered last class. Now we come this gangrene. Gangrene, already we have come across what are the cause of gas gangrene in microbiology. What is the organism involved in gas gangrene? Can anyone type in chat box? What is the organism involved in gas gangrene? Yeah, hmm, Clostridium perfringens. And do you know about dry gangrene and wet gangrene? These are nothing but mm, because of blood decreased blood supply, dry gangrene may be present, and in diabetes patient because of uh, decreased venous return, wet gangrene may present along with infection. Out of these, dry gangrene and wet gangrene is dangerous. Dry gangrene only blood supply will not be there. Infection may present, may not present, but wet gangrene, infection always present along with it. Gangrene, clinical situation where extensive tissue necrosis is complicated by bacterial infection. Dry gangrene. You may have come across with so many people who have lost some fingers or some toes or like that. Because this is due to dry gangrene. Dry gangrene most common cause are atherosclerosis and thromboangiitis obliterans in this all. Atherosclerosis will of the end arteries will cause dry gangrene by decreasing blood supply to the fingers, and wet gangrene predisposing factor is diabetes. See this red color finger differentiates from other because of decreased blood supply. It's when the wasting of the muscle is present in the finger and redness, blackish discoloration is present. The result of ischemic coagulative necrosis. First, you will come across ischemia. Ischemia will lead to what will happen if you won't eat for more days? You will die. Like that only if your tissues doesn't get blood supply, it will die. Nothing but a coagulative necrosis. Black, dry, sharply demarcated infection is in this one, and secondary bacterial infection is insignificant. As I have said, infection may present, may not present. Mostly it will not present because the blood supply is not. Gangrene of extremities in thromboembolic occlusion of wet gangrene. Tissue necrosis is complicated by severe infection. Swollen, reddish, black, whole smelling tissue. Extensive liquefaction. Extensive liquefaction of red tissue occurs due to invasion of organisms and acute inflammation. No clear demarcation between dead and viable tissue. Occurs in extremities and internal organs. Diabetic gangrene of foot. Gangrene of this finger picture is dry gangrene example, and gas gangrene. As you have seen, these blebs, nothing but a collection of gas underneath it. It is caused by, it is also called as Clostridium myonecrosis. Clostridium perfringens, extensive tissue destruction, gas production by fermentative action of bacteria, swollen reddish black foul smelling tissue with crepitus. Treatment, extensive surgical debridement, amputation, and antibiotics alone are not not effective. Along with surgical debridement only this can be treated. Uh, Whatever the infections you have come across needed surgical debridement extensively. Two infections you have come across. One is this one, and another one is. Can anyone type in chat box? This one. Not that so. I will not reveal. Someone answered that, sir. I will not reveal the name, but you can try. You, yeah, necrotizing fasciitis. These both infections are needed extensive debridement. Otherwise, patient will die definitely. Extensive debridement along with empirical antibiotics. Okay, and we some more things. Last class I have said this. What are the skin and subcutaneous tissue? What are the infections which come across? You can take screenshot please and you will know. What are the underlying structures of skin? Epidermis, dermis, subcutaneous tissue, connective tissue, and muscle. These whatever infections we have come across, all these are occurring in this only. See, from below we are coming muscle. We have seen pyomyositis, and we have come across skin abscess present in muscle, and subcutaneous tissue and connective tissue. And that necrotizing fasciitis thing we have come across, and subcutaneous tissue, dermis and epidermis, cellulitis. See this one. Cellulitis. This figure is important. You will come across in so many places. The epidermis involved is erysipelas, impetigo, folliculitis, ectima, parenthesis, carpet. So out of all these, your important questions are cellulitis and necrotizing fasciitis. These are extra more important than anything. Cellulitis and necrotizing fasciitis. What are the organisms involved in cellulitis? Can anyone type in chat box? I have said one code in last class. Nice. Nice is infections which occurs in not streptococcus. Someone said streptococcus. It is staph. Staph is most common. Oh, yeah, streptococcus is also was yeah streptococcus. Someone tell streptococcus. Can you tell the mnemonic of streptococcus? What are the infections caused in streptococcus? I have said in last week. I am typing in. Nice. NICE. Can you expand it? Nice. Nice. N is we can come across these in this slide only. Yes, Smita, both Staph aureus and beta hemolytic. Yeah. Someone said necrotizing fasciitis for N. I for we can come across in this slide only in vertigo. Yeah. C. C for yeah. Cellulitis and E for erysipelas. Yeah, you have followed. Yeah, some at least 4 or 5 people are following the class. Okay, I will go to the next topic. Now we can say what are the infections coming in diabetes patients. Okay, if if your surrounding people are anyone someone asks you what is this infection and all, you can say something. We will go to the next topic. And next important infections topic is hand infection. Mostly you people, mostly you people, so many people have encountered these infections in your lifetime maybe. Have anyone heard of gore chuttu? Huh? Gore chuttu ఎవరైనా ఉన్నారా? It is the most common infection of the fingernail nail bed. Can anyone say what is it called in English? What is the term in medical term? paranoia. This one. Okay. If anyone asks what my finger is training, my nail cut is training, what is this one? Yeah, paranoia. Someone said, yeah, this is the snap. Paranoia. You are seeing this finger now, this nail bed infection. Maybe so many people have encountered in your lifetime. Yeah, okay. You will come across this hand infection. Okay, what we will come across in this PPT: introduction, relevant anatomy, pathogenesis, specific infections, management, complication, and conclusion. Introduction: hand infection is the infection of confined spaces of tendon sheath and spaces, joints, tendon sheaths, and bursa of the hand. Okay. Hand is a tool with which individual can receive information from outside world and then act upon it. It must be supple, sensate, pain-free, and coordinated. What if your all fingers are paranoid, have undergone paranoia? Can you feel? Can you palpate? Can you do any work? No, no. Hand is one of the important relevant anatomy. Maybe you have increased anatomy recently only. Anyway, I will go through it. Relevant anatomy. The spaces of hand are practical significance because they may become infected and distended with us. See this. See these are some spaces in your hand. You may know all these in anatomy dissection classes. Superficial pulse spaces of fingers. What is the infection in these pulse space fingers? In synovial tendon sheaths of second, third, and fourth fingers. Ulnar bursa, radial bursa, mid-palmar space, thenar space. These are diagrams which showing. See this digital. You are seeing right side topmost thing diagram. Here. These are all individual spaces. Dotted line separating them. Okay. And any infection over the head, you should not. While incision and drainage, these are important because you should not cross the creases while incising these infections, incision and drainages. You should not cross the creases. Otherwise, you will infect other spaces also. Okay, and right side lower finger, lower diagram, you can see three bursas, radial bursa, ulnar bursa. Radial bursa towards the thumb side. Thumb side is radial bursa, and towards the little finger side is ulnar bursa. You can see your own hand. Okay? And mid palmar space is nothing but you can see in diagram. Just lateral to the mid palmar space is lateral to the ulnar bursa is mid palmar space, and just medial to the radial bursa is thenar space. Can anyone say on which side hypothenar space will be present? It is towards the ulnar bursa hypothenar space will be present. Edema in hand infections is commonly dorsal, irrespective of location of the infection. Palmar skin is relatively tight and inelastic. Palmar epidermis is also tight and inelastic. Even though you come across most of the infections in palmar side, you will see the edema on the dorsal side. Okay. Mostly after accident and all, even though if you have if you are injured on palmar side only, in the palmar side, you will get swollen on dorsal side. Swollen is nothing but increasing the cells. etiology, bacteria, same organism which is over the skin, Staph aureus. Combination of Streptococcus, Clostridium enterovirus, or other organisms, Mycobacterium species of the and Pasteurella multicida and Echinella organs. Fungal example is Candida albicans. Viral infections example herpes simplex. Predisposing ingredients. Those who use hand more are more infected, and those who use sharp objects frequently, those people will get infected. Manual workers. As you all know, these manual workers, daily wrappers, are um, those who use their hand. Without their hand, they cannot work. And without their work, we will not get food. And housewares. As you all know, your mothers who are working home, they are frequently get infected with their hands. Dishwashers, laundrymen, immunocompromised. Immunocompromised is those who are having diabetes, HIV, and all. And dental workers, those people who use sharp objects frequently, so nail gets infected. And nail chewers, maybe 1% of you are also nail chewers, nothing but eating their nails. While eating their nails, they will get they will eat their skin also, and organisms enter through the breaches, and infection will be there. Mechanism of entry. It may be spontaneous or trivial scratches. Trivial scratches will present, and these people will get entry points of these infections and major injuries, bites from animals, and it will come across the specific infections. Um, so many slides are present, so how many, whatever we can complete in this class, and next class we can with specific infections. Paranoia. As I have said, this is one of the commonest infections we come across. Paranoia or epiponikia. These are infections that develops along the lateral nail fold or base of the fingernail. Maybe you have heard the name Gorsutum. These lateral nail beds are, as you can see, this lower diagram clearly demarcated this infective site. Lateral nail bed or base of the fingernail. Redness of the skin on the side or base of the nail accompanied by localized tenderness is virtually pathognomonic. Phyllon. We have seen the palmar space infection. No? Palmar, not palmar space. This fingernail maximum space in this distal pulse space, right side up. This distal pulse space is infected with phyllon. Superficial pulse space of fingers. Okay, phyllon is a subcutaneous abscess in a closed space of pulp of finger. For this, you have to give incise only small incision, not more than that, and you should not cross the crease. Otherwise, other creases also get infected. This is one of the most painful thing in patient ever had, and patient will, cannot tolerate this infection. And herpetic ulcer. This is a viral infection caused by herpes virus, usually on fingers, caused by herpes simplex virus. The condition characterized by small, swollen, painful blisters and sometimes numbness. Flexor tenosynovitis. Infection of tenosynovial area commonly involves the flexor tendon. Most important of all, hand infection. Because if you don't treat this well, the underlying infection will be increased. Infection frequently follows trauma at the flexor creases of the fingers. Distal crease is most complicated, most implicated. Infection may be secondary from the other sides of the hand. This is one of the important signs. This sign is important in easy entrance exam also. Canaval sign. Canaval sign is nothing but these four features are definitely present in this canaval sign. The canaval sign is a feature of flexor tenosynovitis. Generalized swelling of the finger. See this index finger is generalized swollen and tenderness about the flexor tendency. Flexed position of finger. You cannot extend this. By active extension, patient will feel pain. Pain on attempted extension. Some other deep space infections. Infection in these spaces present as serious surgical problem. And you have to know facial anatomy very properly to treat these infections. Otherwise, you may infect other spaces also. As I have already said, you should not cross the bridges for incisional drainage. Mid-palmar space. Infection usually results from tendon sheath infection of middle or ring fingers. Obliteration of concavity of the palm and presence of slight bulging or pepper. Mid-palmar space is just lateral to the ulnar bursa, as you have seen in the diagram previously. Thinner space infection. Thinner space infection is medial to the radial bursa. Uh, Along the index fingers metacarpus. Thinner space infection involved by direct extension of the index finger and exteriors by widening of thinner area, dorsal edema and ballooning of thinner area, flexion of distal pelvis, but the thumb is not rigid. Hypothenar space. Located deep to the hypothenar eminence. Involvement is usually by direct implantation. To aid diagnosis, there is relative lack of palmar swelling and absence of involvement of the tendon. Deep facial space infections. Dorsal subepineuritic abscess. Swelling and erythema on the dorsum of the hand. Pain with passive movement of the extensor tendons looks like cellulitis. Subfacial web space infection. Secondary to infection of the palmar space. Spreads dorsally. Collar button abscess. And some other are bites. Annual bites and human bites can lead to infection. And pyloneric sinus. Pyloneric sinus is hair implanted in the palm or web space can cause the recurrently infected cyst, resulting in discharging virus. This occurs in barbers, those who are, those who come across sharp hairs while they're daily work, and the hair just um, implanted inside the palmar web space. Web spaces is nothing but the spaces between the two fingers. This causes a recurrently infected cyst and resulting in discharging virus. And septic tonsillitis, osteomyelitis, and mycobacterial infection are infections along with this hand management. Management is as these infections are most painful, you have to treat early and accurate, careful assessment improves the outcome. History. What are the history patient will come across in these infections? Hand pain, swelling, loss of function, drainage, penetrating trauma, annual bites. Onset and duration will come. You have to know. And constitutional symptoms, example fever and hand dominance. Which hand dominant along with that and occupation and pre-morbidity is diabetes. Examination. General. Ill-looking, painful, distress, febrile. As you have to express these things, those patients who have small infection and inflammation also, they will present with fever. And those who patients, so many patients who have fever also, they look so ill because of whole body. These inflammation factors affect whole body, and these looks like those patients are ill looking. Specific like skin point of trauma, bruises, bite point, pointing of the abscess. Soft tissues, um, edema is easy, bones, deformity in osteomyelitis, joint swelling, in septic arthritis, limitation of movements of hand, and canal cell. These are some specific features of these infections. Investigations. This is also clinically diagnosed in many, but some infections you may need to treat the underlying cause like diabetes and to know the what is the organism involved is. And for that aspiration of us for culture sensitivity. Tissue biopsy for histology. Histology. Full blood count DSR increased WBC with neutrophilia. Treatment. Prevent swelling by elevating hand. Normally you will hang the hand like free hand, but in these infections, if you normally leave like this, venous drainage will be hampered and hand gets swollen. So for this thing, you have to elevate the limb always like this. As you see that as fractured patients, like fractured patients, you have to get this limb elevation. Use of arm sleeve above the level of heart, elevation of below, hanging the affected limb. Medications. Antibiotic. Broad spectrum antibiotics is needed for these infections. And tetanus serum can be given. Analgesia. Tetanus TT to prevent which infection? We have seen in last class. Gas gangrene. Like gas gangrene organism, one other organism is there. Clostridium perfringens. Another organism, Clostridium tetani. Analgesia, opioid or NSAIDs can be given to relieve the pain, and acyclovir for hepatic pillow, and anti-TB for mycobacterial infections. Surgical treatment is nothing but surgical drainage, incision and drainage, and you have to know the facial planes properly to create these drainage infections with proper drainage. If pus is present, adequate this surgical drainage to be done, and adequate anesthesia, GA and digital block to be given. Otherwise, patient will feel so much pain. Tourniquet to ensure bloodless fluids. Appropriate positioning of hand. Tendon sheath at each place first needs irrigation. See, these are some infections which does not cross the creases. For pulp abscess, first infection, first incision, and distal tendon sheath infection like this. And extensive tendon sheath infection, you can see the V shape. That we are not crossing the crease. We are avoiding the crease by giving this infection. And for web abscess, you can see the incision. And for thinner space infection, plastic. Plastic. Uh, thinner space infection, incision you have seen this. And the space of corona for this infection, this incision will be given. We have to do. Collar stud abscess. Collar stud is collar. What do you mean by collar? Normally, collar shed collar will be there, no? Like both sides it is infected. See this diagram, left side diagram. Black black thing is infection, which is present in both palmar and the dorsal with small connection. This is a palmar stud abscess. For this, both palmar incision and dorsal incision both should be given. And for paranoia, epinoia, this is technique. Technique if localized to one side, you can remove this nail bed if it is recurrent. Normally, this is not required in paranoia. Normally, you may come across this subsided on its own, or if it is smaller infection, if patient is diabetic or not, you may not have to give antibiotic. Bites should be explored, debrided, cleaned, and managed with broad spectrum antibiotics. Wound is left open. The pus obtained is sent from most culture sensitivity. Hand should be re-examined 24 hours after. One principal rule for these treating infections are never close the wound. For any infection, you should not close the wound. If you close the wound, you may end up to the jail. Remember my words. If you are becoming surgeon and if you have treated some infected part, and if you close it, definitely it will not succeed. Patient may land up into the sepsis and patient will die. So never close the wound if it is infected. Only secondary closure is required in these patients. No direct closure. Okay. Examine the hand after 24 hours of drainage. Spleen test. Spleen test is nothing but immobilization of the hand in glass folding position. See this glass folding position. You will come across this glass folding position in your orthopedics. Uh, Safe immobilization can be done in this position. This is some pain-free position. All infections need early mobilization once inflammation subsided. Okay. Otherwise, patient may get lazy. It will not move on its own. You may need physiotherapy. Some complications of hand infections: tendon destruction, sepsis, functional disability, extension into the forearm, compartment syndrome, septic arthritis, osteomyelitis, contractures. Surgical intervention: injury to the hand structures. Conclusion: hand is an important tool to livelihood. Rapid, precise diagnosis and quick surgical intervention makes significant difference between the patient losing his hand or getting back his livelihood. Okay, thank you guys. We may end up your session. Have you gotten anything useful in this class? Yeah, I have given PDF to this this organizer. You can take from here. Okay, then I'm leaving. Thank you guys. For those who listen class and for those who not listen class, no thank you.
చాట్ బాక్స్ లో అందరూ అటెండెన్స్ పెట్టారా? హలో హలో హలో